that with us as an inspiration. For those of you who don't know me, I'm Dorothy Poppe. I'm the Executive Director of CSF. I had done some slides, but I'm not even going to go through them to keep us on track for time. What I do want to ask you to do is to get a brochure tonight. It's the peer registry, which means platform for engaging everyone responsibly. CSF has taken the time to go back, create all of the common data elements for this registry. It took us a longer time to get started, but it's been revisited, and all the elements that are in there are good to go with other registries, so it's a great place to start. We're encouraging you, whether you're doing extremely well, if you're doing well, sign into the registry, take your diagnoses, go through, it's a promise, which means like a quality of life, how's your quality of life going, resource in there. And the goal is, if we can get Chiari Syringomyelia, EDS, dysautonomia, all of those comorbid, and I am only naming a few, into one place, then physicians can go back, like Dr. Henderson, and say, I want to find out how many people with XYZ need this or respond to this. So, but if we have a separate registry for EDS, a separate registry for dysautonomia, a separate registry for Chiari, it's hard to do that. So this is an international registry. If you go in, if you have any to it, it's really simple. Right there is the code to get to it, the HTML, whatever it is. And then you're going to get asked for a code, and we're using the FH4CSF as your code, and what it says is you were here at a lecture, and that's how we found you, and that's how you made it to the registry. So it's a good way also, if Dr. Henderson wants to go back and look at his patients, he can go back and look at those too, or wherever you come from. So please, if you really want to help, if you really want to be the key, take the half an hour, take a brochure, take the half an hour, go home, fill it out. It's not a research project. It's a place where research can be done. So if we get enough people in here, then we can really start to understand the differences and the similarities between all of the comorbid conditions. So I encourage each one of you to just please go home and do that. If you do that, you're helping to find the answers. So with that, I'm going to turn this over to, are we going with Dr. Liu first, or Fraser, Dr. Henderson? I'll bring you up. Real quick.
I'd like to thank everyone for coming this evening. We're very honored to have Dr. Peter Rowe from Hopkins, our own Miles Kobe, who has done so much work with neurovascular. Sarah Merritt, a brilliant pain doctor by way of Hopkins. Dr. Mova, who helps run our stroke center and is here to think about strokes and venous hypertension. Stacy Fisher, our second speaker, will be here momentarily. Our third speaker, that I suppose we didn't really have time for three speakers tonight anyway, but Hassan Abdallah is a leader in dysautonomia, and he had to leave urgently 2-3 days ago to Vietnam because his son had contracted a pulmonary condition, so he's flying there to rescue him, and by way of Korea and roundabout path. So thank you all for coming. Before I introduce Dr. Liu, let me say a few words about the topic we're going to discuss tonight, and that is of venous hypertension. So understand that every milliliter of blood that flows into the brain also has to flow out, and similarly with the spinal cord. And if there's any obstruction to the venous outflow, this causes a backing up of the blood and venous hypertension, and it has neurological consequences. So in the brain, for instance, the presence of dural arteriovenous fistulas, where arteries can communicate with veins, can lead to a big increase in venous pressure. And if there's any blockage associated with this, blockage of the venous outflow, it results in memory loss, cognition problems, and ultimately thickening of the vessels and dementia and even death. So in the spinal cord, we see the same thing with the various forms of arteriovenous malformations. They cause an increase in venous pressure. And an increase in venous pressure means abnormal physiology in the nerves, and we see a whole manner of neurological problems expressed in the arms and legs. Leg pain, change in gait, bowel bladder problems. So arteriovenous fistulas and other forms of arteriovenous malformations are fairly rare, but Dr. Liu is going to talk about other forms of venous hypertension, and that he sees many of these on a daily basis. And in our practice, we see a fair number of them. But I want you to sort of expand your minds to be thinking of everything from heart failure to portal hypertension due to liver cirrhosis to infections in the spine and other abnormalities of the spine that can interfere with blood flow. And you say, why would blood flow down the spine matter? Turns out, and I think neurosurgeons have, including myself, have difficulty believing this, but a number of authors, and you might want to comment later on this, have shown that the blood flow down around the spine is as important as the blood flow through the jugular veins coming out of the brain. So if you interfere with the blood flow around the spine, then you can cause venous hypertension. So this is a big problem that certainly would you agree, Dr. Mova, in neurology and in neurosurgery, Dr. Liu, would you agree that we have not been addressing this problem very well? I see an affirmative, two affirmative votes there. So with that in mind, I'd like to introduce Dr. Fisher to talk about causes of intracranial venous hypertension. And then Dr. Fisher from Maryland University will be talking about some of the cardiac causes of venous hypertension. Dr. Liu is a vanguard and one of the true leaders of this field in the world. And he has close to 90 manuscripts published and half as many posters. He did a baccalaureate at Berkeley in molecular biology, then medical school at the University of Southern California in LA, and then his residency, chief residency, and then a fellowship in neurointerventional radiology at Oregon. And he was then recruited to the University of Virginia, where he was co-director of the Comprehensive Stroke Center and director of the neurovascular interventional radiology. And then more recently, he was recruited to Penn State at Hershey, where he's now an associate professor of radiology, associate professor of neurology, and associate professor of neurosurgery, soon to become professor, I'm sure, and in an expanding program, and he is really leading the field. So we're very pleased to have you here, Dr. Liu.
So thank you all for having me. I have to apologize. I literally ran out of the operating room as fast as I could to make this meeting. And so I know I look like poo and probably smell even worse, but if you'll bear with me, I would appreciate it. It turns out if you get pulled over and you're wearing scrubs and you tell the officer you're a brain surgeon and you cry a little bit, they'll let you off. They'll let you off. So how do I go forward? So I always find it entertaining when Dr. Henderson introduces me because he's describing this guy that I don't know who this guy is, but I think what it tells me is that Dr. Henderson, you may need a shunt or a stent. I don't know if your memory may be going, but I certainly appreciate the opportunity to speak to you guys. It's always heartwarming to hear your guys' stories, especially cars. And it always amazes me the struggle of it all, and how it affects all of your guys' lives. And I think what I'd like to say before I go into this boring talk is that I think sometimes you guys feel like you're sort of left behind by the medical community in a way, and are kind of left off by the side of the road, and are kind of behind everyone. But what I really think is, and hopefully this talk will illustrate that, is that you guys, I know I'm not very bright, but you guys end up outsmarting me at almost every turn. And so I think it's actually you guys that are driving the curiosity of some of the physicians and surgeons here to try to re-understand or relearn what actually all is going on up in the head. And I think it's this small population of people with EDS or Chiari that'll end up pushing the field forward because of how strange and different you guys are. So I hope you guys can keep that in mind. Of course, there are a couple financial disclosures, none of which pertain to this talk. I am a consultant for some of these companies. I do receive research and educational funding for training fellows. Again, none of this should impact anything that I have to say. So as Dr. Henderson said, I'm a blood vessel guy. I trained to treat problems with blood vessels. And when you, in the brain and in the spinal cord, when you think of blood vessels, you think of stroke. And stroke is a terrible, terrible problem. You get on the internet, you get on the American Heart Association, everything will tell you how bad stroke is. Almost 1 million people per year in 2020 will be affected by a stroke. And it is a leading cause of adult death and disability. So stroke is bad. Now here are some examples of strokes. Strokes are like when brain aneurysms rupture, when you have a blocked artery in your brain, or you have other arteries that explode in your head, other malformations. These are all strokes. And what's interesting is that stroke, if you think about it, stroke is actually a problem with arteries. And arteries are the blood vessels that carry blood from your heart to your brain. All of the devices that I use, all the little toys and doodads I use in my special little room, these are all FDA-approved devices for arterial problems. Now, if you look at the medical literature, if you search artery versus vein, you'll see that about 2/3 of the medical literature of the entire body talks about arteries. Doctors are very, very interested in arteries. If you just focus that in on the head and the neck, that number rises to 83%. So everyone's very, very interested about arteries. But the thing is, in your body, there aren't just arteries, there are also veins. And it's not mostly arteries or mostly veins, it's kind of half and half. And so there's this whole population of blood vessels that no one really pays attention to, and have always kind of been cast, sort of disregarded. And that's kind of what I want to focus on today. And so this talk I sort of put together to sort of illustrate I know you guys go through a journey when you with EDS. I've gone through my own journey since I started interacting with you guys. But it's very clear what artery problems are, and we're not so clear about what vein problems are. Are there vein problems? What are they? Can they be fixed? So as Dr. Henderson said, this is an example of a dural arteriovenous fistula. This is just a blood vessel malformation of the brain, and this is actually a 53-year-old carpenter from Egypt. He immigrated to the U.S. long ago. He's actually bilingual, and he noticed that over a period of about a year or two, he started getting headaches, started not feeling so well, started having difficulty using his hands to work. But most interestingly is he lost the ability to speak English. And this puzzled a lot of doctors, and so he eventually ended up getting scanned, and it turns out he's got this raging dural fistula here, which is basically a bunch of veins that are now under high pressure from blood, and so we ended up fixing this, and a lot of his symptoms actually ended up going away. This is another example. This is a 63-year-old internal medicine physician. She was running her own practice, noticed over the past maybe 5 years that she was having increasing difficulty running her practice, remembering things, scheduling, remembering patients, stuff like that. And she actually went to see a neurologist and was given a diagnosis of Alzheimer's disease, and said, well, you got Alzheimer's, there's nothing we can do for you. we're very sorry. She ended up getting an MRI, and what this shows is a very large arteriovenous malformation, another blood vessel malformation, where there's an abnormal connection between arteries and veins that essentially produces high pressure in the veins, so that the veins can't work like they're supposed to. We ended up taking this out, and she actually made a full recovery. So she's very happy that she did not have Alzheimer's and that she could go back to working. Now, these are some very clear examples of venous hypertension in the brain, venous problems in the brain. But like Dr. Henderson said, they're very, very rare. Now, it sort of, makes us think, or made me think, are there other possible surgically treatable conditions that arise from bad veins? And the answer, obviously, because I'm here, is yes. And I'm going to quickly talk about this condition called pseudotumor. A lot of you guys have probably been diagnosed with it. It goes by many names, commonly idiopathic intracranial hypertension. But it really is a syndrome of headaches. People lose their vision. They sometimes hear their heartbeat or a noise in their ear. And this is often treated either with pain medicines. Doctors tell the patients to lose weight, even though some of them are actually normal weight. We try medicines like Diamox to try to decrease the pressure in your brain. But this is one of those things when, as a neurosurgical resident, when I was training to be when I was a baby neurosurgeon, whenever you received a call from a doctor saying they had a pseudotumor patient, you would sort of have this PTSD response, because it's one of these conditions that are very difficult to treat. Surgeons, or I should speak for myself, we're not very bright, or I'm not very bright. I like problems that are easy to fix, that have a well-defined natural history, a well-defined repair. We fix the problem and then we move on to the next thing. Pseudotumor was really not like that back in the day, and we never really had a good grasp why. But the sort of traditional way of fixing or helping patients with pseudotumor was to decrease pressure in the brain. That's typically done with what's called a shunt. Sometimes for ophthalmologists would fenestrate the optic nerves to try to save vision. And of course, there's my favorite, which is sort of this idea that's increasing in popularity, is that there's a subset of patients with pseudotumor or with intracranial hypertension that actually have a problem with their veins, and the veins are narrowed, causing blood to back up, which causes the brain to become very congested and can actually increase the pressure. And that's a narrowed vein is actually something that we can fix. Narrowed vein here before stent placement, narrowed vein here after. So. Very easy way to fix this problem. Now, back in the day, this was considered a very experimental treatment. These days, I think we've come a long way. There's a lot of literature now that has demonstrated over and over again not only that this idea is real, but that it's safe and is effective. I was lucky enough to be one of the first authors to help contribute to one of the first large series of patients who are undergoing stenting. And if as you go through all these slides, you'll notice that now there are a lot of review articles now. So there's a tremendous number of patients, tremendous number of amount of data that's been collected now about how safe and effective this is. If you sort of look at stenting, which is on the right here compared to some of these other treatment options. The blue bar is how much better patients get with their vision. Red is how much better they get with their headache. If you look at stenting over here, there's a very favorable profile over lumbar shunting, ventricular shunting, and optic nerve sheath fenestration. So I think this, because of data like this idea of venous stenting to treat patients with pseudotumors is gaining in popularity. And if you're lucky enough or unlucky enough to go to some of the national neurosurgical meetings, there are now a lot of these dedicated sessions to treating venous disease, which just a couple of years ago they did not exist. Now, as I started to do more and more of these cases, I started to think about how does stenting the brain actually work? Are we improving blood flow? Are we decreasing the pressure? We know. When a pseudotumor patient has a spinal tap or a shunt put in, that sort of lowers the pressure in the brain, and that makes the patient feel better. Does stenting kind of work the same way? And this is a lot of you guys who have seen me talk, this is one of my favorite examples to give. But this is a young lady who basically presented with double vision. Her eyes weren't working. As you can see, her eyes are really cross-eyed here. And when a patient suddenly develops double vision or cross-eyedness and they go to see their eye doctor or a neurologist, one of the things that concerns us is the possibility that the intracranial pressure may be too high. So she came and was admitted to the hospital. We put in a pressure monitor and showed that her pressure was in the 60s. Turns out that she's got florid papilledema, or losing vision, and you can see that her eyeballs don't line up. So clearly, someone whose brain is not very happy. Now, we did an angiogram. We showed that she's got terrible, very severe venous transverse sinus stenosis here on her left side. She underwent stenting, and one of the interesting things that we did, this was several years ago now, or many years ago now, is that you can see the pressure monitor is still in her brain. So this sort of allowed us to watch in real time how stenting affected her intracranial pressures. And what was really interesting is that during the procedure, as soon as we put the stent in, her pressure started to drop almost instantaneously back down to a normal level, which is something that we had kind of thought would happen, but we didn't think it would happen that quickly. So there were a lot of high fives in the room. 3 months later, you can see her eyeballs look great, and most importantly, now her eyes not only have makeup on them, but they everything lines up now. So this led us. This is, of all the things that I've done in my life and professionally, this is probably one of the things I'm most proudest of. This is the paper that we show all the insurance companies when they say that stenting is experimental. So this is a paper where we basically took 20 people. We put in bolts. We stented. These are patients with pseudotumor. We put in stents and watch what happens to what happened to the pressure in each of these patients. And as you can see, everyone's pressure normalized within 24 hours. So this sort of gave us a lot of ammunition to sort of push stenting as a treatment for some patients with pseudotumor. That the way it works is by lowering the pressure in the brain. Now, pseudotumor is a fairly rare condition. It's about 1 in 75,000. 1 in 60,000. You guys are probably saying, well, why are we talking about something that doesn't really apply to very many people? You were at the beginning of the talk, you're talking about how bad stroke is and how 1 million people every year are going to be affected, and now you're talking about this super rare thing. Well, it turns out that this condition actually is probably more prevalent than we think. And there was several years ago a group of people contacted me because they noticed that the patients that I was taking care of had similar problems to the patients or to the people, to their employees, and that was NASA. And that's actually James Polk. He was the chief medical officer at NASA at the time, but we've since collaborated, and there's some very interesting things that happen to the human body in microgravity environments. And as one of the things that we have here on Earth is gravity, and that drastically affects, or it's intimately affected with how blood flows around our bodies. And our bodies evolved in an environment with gravity, and actually uses gravity to help it do things. And they noticed that there are some of the astronauts, especially spending a lot of doing long spacewalks or spending a lot of time in space, would come back with a lot of symptoms similar to patients with pseudotumors. That they would sort of have these chronic headaches. They had papilledema. Sometimes, once they returned to Earth, some of that would go away. Sometimes it wouldn't. But it's it becomes a problem because as soon as we start talking about sending people to the moon or sending people to Mars, where these trips are months and months long, you really want your astronauts to be able to think, to be able to see. There are probably a lot of little things that you need to see. And so we've developed this. I don't even know remember Scott Kelly, but there's a lot of devices on the space station now that the astronauts actually use that can look and they just put up to their eye. They look and something happens so that they shine. It looks in the eyeball and then beams all the data down to Earth, where doctors in Houston and around here can kind of keep an eye on things. So obviously. You can see there's some ultrasound examples of these space station ultrasounds, but as you can see, I had no idea there are so many things to look at. It's even more complicated than brain surgery, I think. So, it sort of piqued piqued my curiosity. Now, again, you guys are saying, you know, how many astronauts do you guys know? I don't know any astronauts. You know, we're still talking about very limited groups of people, and you guys are probably thinking, you know, I don't really care. You know, talk about something interesting. So, this is. I'm going to kind of move into patients with Ehlers-Danlos and sort of talk about my journey here. This is one of the first patients that I treated. This is a person that came to me and had you know basic triad of pseudotumor: pressure headaches, losing blurry vision, heard a noise, and along with a host of other symptoms, including brain fog and stuff like that. And every doctor that this patient went to said, you know, there's nothing wrong. Your MRI looks normal. I don't see any papilledema. You know, you know, I don't think you have pseudotumor. These patients, you know, you guys are very resourceful, and you get on the internet, you try to look for solutions on your own. But somehow this patient ended up with me, and said, this is what I feel. We took some pictures. Their MRI matched up with you know, a lot of the MRIs that I typically see in patients with pseudotumor. And I said, you know, I know exactly what's going on. You have intracranial hypertension. You know, we're going to put in a pressure monitor. It's going to be very, very high. We're going to find a narrowed vein, and then we're going to stent the vein, and your pressure is going to go down, and you're probably going to feel better. And I felt very proud of myself. So, you know, we did an angiogram. Everything was kind of lining up, and then we put a bolt in and noticed that the pressure was only about 17. Now, 17 is really on the border between normal and high, sort of in this gray area where we don't really know what to make of 17. So I said, well, you know, maybe the brain's is having an off day or something. Maybe it's really high, but maybe today it's just low or something like that. I had a long conversation with the patient. They eventually agreed to undergo a stenting procedure. So before and after. And you can see the ICP is now 14 after the surgery. And we're like, well, that maybe, you know, looks like maybe we lowered it, but, you know, ICP is something that varies throughout the day. So these are just snapshots. So I would say that, you know, looking at this patient's record, that her ICP probably didn't really change that much. Now, the funny thing is, the patient got dramatically better. Almost everything went away, and that kind of left us scratching our heads. You know, we sort of assumed that we would lower the pressure in this patient, but we actually didn't really, and so maybe it's not a pressure thing that's going on, and that's sort of borne out over the past 3 years. And you know, the funny thing with stenting in you guys is that sometimes the results are extremely dramatic. We have patients who have been given a diagnosis of Alzheimer's. A patient from, I think, Richmond Suffolk called me recently, just out of the blue, because this was a patient who had been diagnosed with Alzheimer's and her marriage was failing and was sort of very depressed, and given this terminal diagnosis, she ended up getting a stent, and she went back to normal. Marriage is back on track. So she called me about a year and a half later, very, very happy that such a simple 10-minute, almost outpatient procedure could almost, you know, cure her Alzheimer's. We've had patients who are almost blind have their vision return. Those of you who have seen this talk before know that there are patients who come to see me in wheelchairs and then are able to walk again after a stenting procedure. And so some of these results are very, very dramatic. And when I tell other doctors about this, they're like, that can't be. You know, these are just miracles. This is a select few cases that that you're showing us. This is what I call the Instagram effect, where, you know, you just pick the best cases or the best pictures to show of yourself, and you don't really show everything else. So what I want to quickly go through is everything else. So this is some data. This is from a slide. I was just at Stanford, but so some of this talk is parasitized from that talk. But this is data up to middle of 2017. So I kind of updated this. So now I've seen about over 200 patients. A lot of patients. A lot of you guys, almost all of you guys, have some kind of hypermobility syndrome. Most of you guys have some kind of Chiari diagnosis. There are so many different kinds of Chiari now that I myself can't keep track. But a lot of the symptoms, you know, these are a lot of symptoms that you guys will all see: headaches, brain fog, vision. Some of you guys present with very strange symptoms, like one side doesn't work as well as the other, or I had a patient tell me that they couldn't taste like they used to. Some people come in with numbness, numb fingers and toes. And these are all things that I'm like, well, I don't know if that's related to anything, but as soon as we put in a stent, all that stuff gets better. So some very, very strange stuff. For those physicians who are very nervous about sticking catheters into patients with a connective tissue disorder like Ehlers-Danlos, a very, very, very low complication rate. We only had one dissection, and that was a technical error, meaning that I wasn't watching the fellow or the trainee as carefully as I should have. But we've treated 161 patients, put in a total of almost 300 stents over the past 2-3 years. Now, the interesting thing is that for the most part, everyone feels better at about 3 months. About 85% of people that I speak with feel better. And again, this is 2017 data. Headache improvement, it's 49%. Some people have a new headache from getting a stent. And back then, when I was giving this talk, I noticed that 21% of patients, we ended up putting shunts in because the stent didn't do whatever we wanted to do, and we ended up looking at their CSF and noticing that that putting a shunt would make people better. Again, this was 2017 data. Now we're now a year later. What do things look like a year later? Okay, so 85% still feel better. Headache improvement probably a little bit less, but look at this. Look at this. 40% have undergone shunting. So clearly, venous stenting or fixing blood flow or this magical stenting procedure may or may not be the answer. We're probably fixing something, but it really makes me think about what is all going on. What is it that we're actually fixing? We know in pseudotumor we were kind of reducing the pressure, and that was helping patients. But in patients with EDS, we ended up sciencing the shit out of all this stuff. But things are probably a lot more complicated. The situation is probably a lot more complex than we think. One of the interesting things that we did an experiment when I was in Virginia where we're trying to understand how pressure in the brain or CSF in the brain affects how veins look. And so we found a pseudotumor patient, talked to them, and asked them to volunteer for this, which thankfully they did. But the basic idea was, what do veins look like when the brain is under high pressure, and what do veins look like when the brain is under low pressure? And this is all real time, so we put the patient on the angiogram table. We did an angiogram, saw a narrowed vein, kept the catheter in there. We rolled the patient on their side, did a spinal tap, high volume spinal tap, took about 30-40 cc's, and did an angiogram again. And you can kind of, this may not be convincing to you guys, but you can kind of see the vein, this vein right here, this one right here is the one that we're interested in, is much, much larger. And so we were actually able to magically, open a vein, something that a stent would do just by doing a spinal tap or putting a shunt. For those of you who don't believe that picture, we actually took an ultrasound and stuck it in the vein. This is before the spinal tap. This green thing is the vein. This green thing is the wall of the vein, which you can kind of see. It's very, very, very small. And after the spinal, again, this is all real time. This is immediately after spinal tap. We did an ultrasound of the vein, showed that the vein was now in normal caliber again. So just because the patient has pseudotumor and has a blocked vein, doesn't mean that they necessarily need a stent or that it's a blood flow issue. And this has been a debate that's long been in neurosurgical circles is how the veins and the spinal fluid play with each other. Is it the veins that go bad and then start everything, or is it kind of the other way around? Some other interesting articles that came out of my group at Virginia, but there are a lot of people walking around with narrowed veins, and these people don't have any problems. We randomly picked 550 CAT scans and looked at people's veins and found that almost 40%, 33 or 37% of them actually had transverse sinus stenosis that was characterized as moderate to severe. Now these are people walking around, granted without EDS, without any other symptoms, but this is, just because you have a vein that looks bad doesn't mean it's necessarily causing problems. On the flip side, you could have patients with terrible symptoms, and you do an angiogram on them, and only about, this is from Philippe's group in Phoenix, but only, again, about 38% of them only have veins bad enough to qualify for stenting. So, what this tells me is that we clearly do not know enough about what is actually going on here. And these are just some boring articles and a lot of literature about anesthesia, and again, just us trying to figure out the science behind, what's going on here. Some art manuscripts from the Hopkins group here for Dr. Rowe. But you can see there's a lot of stuff that we're trying to figure out. These are all articles that have been published in the past 2 years, trying to understand how things like anesthesia and body mass index and stuff like that affect things like the pressure in the brain and outcomes with venous stenosis. And so a lot of this stuff is brand new. We don't know what it means, but we're trying to figure out if it means anything. Now, again, this is not. This is very puzzling to me, right? It sort of makes me think, what is it that is actually broken? Is it the spinal fluid that's actually broken? Is it blood flow, right? How does broken spinal fluid lead to increased pressure? Again, if you allow fluid to build up in the brain, you get what's called hydrocephalus, which is too much water on the brain. But patients with pseudotumor don't have that. Your ventricle is actually too small. Where's the, if it's a backup of fluid, like where's the pressure coming from? Where's the fluid? There's no fluid there. The same thing with the veins. If your veins are backed up, where's this pressure coming from? And why are high pressures bad for the brain? Why does the brain not like bad pressure? It's not like, if you have high hypertension or high blood pressure in your body, your arteries get harder, their scar tissue builds up, there's more inflammation that occurs. What does high pressure in the brain do? Does it make your brain not work as well? And again, I'm not the brightest guy. I'm always surprised that I got into neurosurgery. And so, when I'm faced with a problem like this, right? You want to have someone you want to call and ask. I need some help. Who are you gonna call? And so, I thought, God, who is the smartest person I know? Who's the person who's a genius and that I look up to? Oh, so I called Dr. Henderson. Dr. Henderson was operating, so I got, okay, God, can't ask Dr. Henderson. Who's next? Douglas Adams. I don't know if you guys know Douglas Adams, one of my favorite authors. I wanted to ask him, but he actually passed away from a heart attack in the early 2000s. So I said, God, who's next on the list? Oh, Steve Jobs. Oh, he's dead too. I gotta start finding heroes and mentors that are people that I idolize that are not dead. And so number 3, do you guys know who these people are? Anybody? Strange. Metallica. Yeah, Metallica, right? These guys I idolize. I think their music is genius, right? So I gave them a call, right? We kind of all got together. I gave him a crash course in brain surgery, and I put on my thinking guitar, and so when you go back and you look at the data, the thing that really struck me was you guys present with a lot of what I call pissed off brain or brain dysfunction. There's no medical name for what you guys experience except that the brain's just kind of pissed off. It's short circuits. It's sometimes it works okay and sometimes it doesn't. But that's kind of where I started to, where I kind of started to look. And if you kind of break down what's inside the skull, there's 3 basic things inside the skull. You have blood, you have your brain, and then you have the spinal fluid or the water. And when the brain breaks or when the brain gets dirty, all that stuff falls into a group of disorders that I call the neurochemical dementias. These are things like Parkinson's and Alzheimer's. These are all these neurodegenerative disorders that you hear about. There's certainly a group of disorders caused by bad blood vessels that we call vascular dementia, and you guys may have something very similar to that. And then when the spinal fluid breaks, people can have similar symptoms. So it turns out that you can break any one of these, or all of them, and you can get a picture where the brain doesn't really work or gets pissed off. And I thought, well, they all sound so similar. There's got to be something connecting the three of those things. And one of the things that's starting to gain popularity in the past 5 years is this idea of what's called the glymphatic pathway. Now, this is, when in medical school, they kind of said, the spinal fluid is what your brain floats in. We don't really know what it does or where it goes or how it circulates, but it's kind of there, and maybe it washes your brain or it helps your brain float. But if there's too much of it, it's bad, and that's basically all they taught us. But it turns out there's this idea that spinal fluid doesn't just float around your brain. Spinal fluid is actually pushed through your brain, and as it's pushed through your brain, your brain cells are very, very dirty creatures. They poo a lot in all these little brown spots. These are little things that get washed away as the fluid is pushed, as the spinal fluid is actually pushed through the brain. Now, the interesting is, well, where does it go? There are a lot of elegant experiments now. These are some experiments done by Jeff Iliff. He's in Portland, Oregon now, and Mike Niedergaard, who's in Copenhagen. But so basically, they've injected stuff, bad stuff. They injected something called tau, which is something you see in Alzheimer's, but they injected it into a mouse brain. And over time, they kind of watched what that glowy green stuff does. And if you actually watch it, it'll actually, not only does it move, or it kind of moves, it diffuses through the brain, but it actually diffuses and moves toward the veins where they get emptied. Now, they've done a lot of experiments now showing that when you take out certain water channels that, like something called alkaporin 4, that you can inhibit or break this brainwashing system. If you smack the brain, if you generate a traumatic brain injury, that breaks this system. So it's this interesting idea of how the brain washes itself, how the brain maintains itself. Is this glymphatic pathway? Again, here are some manuscripts describing this. Now, what's interesting is even though this is a spinal fluid washing kind of a thing, this is a pathway. This glymphatic system is a pathway that actually is very dependent on healthy brain, healthy spinal fluid, and healthy blood vessels. So it's actually the pulsations of the artery that actually help push the spinal fluid through. Now, if you think about it, patients with Ehlers-Danlos, you guys have or some kind of connective tissue disorder. This connective tissue is not just in your joints, or it's not just in your skin. The connective tissue is everywhere in your body. It's in your eyeballs, it's in your intestines, it's in your blood vessels, it's in your brain. And so if your blood vessels, if your arteries are broken and they can't contract and pulse like normal, maybe that's what helps break this system. If your brain isn't put or held together just right, and it's too stiff or it's not bouncy enough, that can break this system. If your veins are bad, if there's a backup of blood and your veins aren't working, that can break this system also. So this is what I'm working on now. I'm certainly very fascinated with this system, particularly now that we also know that this pathway is most active at night when patients or when humans are asleep. And I think when I was little, I always thought about, well, why do we need to sleep? I want to stay up and play video games and eat candy and I don't want to sleep. But it turns out if you don't sleep, you feel terrible the next day. Or if you don't sleep for several days, you feel even worse. But what happens when mammals sleep, right? Sleeping is a very strange activity where your mammals make themselves completely vulnerable for a third of their entire lives. So it must be evolutionary, very, very, very important. Well, it turns out that maybe it's because this is when the brain is able to kind of clean itself. And so that's why we need sleep, so that we can keep healthy brain. So we've done, again, a lot of, this is some of the stuff that we're currently working on, where we've got all kinds of tubes and stuff in the brain. We're measuring pressures and blood flow with patients under anesthesia, with patients who are undergoing shunting or some kind of CSF diversion procedure, and looking at what happens during those things. We're trying to develop new imaging pathways. Now, this lymphatic system has never been actually proven in a human. Right? This is something that's been demonstrated in a mouse or in rodents, but it's never actually been. The way they demonstrate it in rodents is they sacrifice the animals and harvested the brain. I can't do that with you guys, not yet anyway. And so no one's been able to really demonstrate this pathway in the live human beings. So that's one of the things that we're kind of working on now. A lot of the stuff I do is invasive with bolts and catheters and pokey stuff, and most people don't like that. And so we're working on some new MRI sequences that can that can help us not only look at blood flow, analyze blood flow non-invasively. I'm also working with a group at Penn State. There's this new modality called photoacoustic imaging, which basically, if you shine a laser on tissue, that tissue will actually start to resonate and produce a sound. Now, most of us can't hear it, but you can actually hear it with an ultrasound transducer. But we're thinking that this may allow us to actually image the movement of particles in the brain in a live human. So this is something that I'm very excited about. But again, whatever we're talking about, when I go in and I speak to you guys, I really just, I'm really good at fixing blood flow. Or maybe it's kind of good at fixing spinal fluid flow. But when you think about it, it's really not just one of those things, or it's really not two of those things. It's this, again, the situation is probably more complex. And so I think trying to simplify it is probably not the best thing to do. And then again, I'm very focused in the head, but there's certainly a lot of patients I see with jugular vein stenosis in the neck, which can cause very strange spinal cord problems and brain problems as well. And as you move down lower, right, you can have narrowing in any of these veins. Anything that prevents blood from getting to the brain, back to the heart, can produce a picture of venous hypertension and affect spinal fluid or brain stiffness, or who knows what else is going up there. We're currently working with a group at the University of Trento in Italy, where they actually have supercomputers. So we're actually trying to mathematically model a lot of this stuff. So they take a blood vessel, they break it down into a bunch of math equations. They pick a bunch of spots, and all this stuff is actually modeled. And it's not just. And I know I'm just showing the veins here, but they've actually modeled the entire blood and spinal fluid system, all the way from the heart up to the top of the head. So there's equations taking into account the pulmonary circulation, all the elasticity of the arteries and veins in the neck. There's a CSF compartment. We're in the process of adding a brain compartment now. So the brain is not just a bystander. Every time blood goes up into the brain bounces or does something. It does something to help. Again, that I think is all part of this glymphatic system. So I think there's some very exciting work coming out. This is unpublished data, but this basically says that I think we're kind of on the right track. What these squiggly blue lines are basically saying is what the math equations predict is actually what we're finding in a real person. So I think we're on the right track. So if you kind of go back to things, I started this talk by talking about stroke and how bad stroke is, right? 1 million people for every problem for someone with an artery problem. Now, if you think about it, if you from a business and a market standpoint, if you're looking for a market, you want the biggest market possible, or you want to, as a physician, you may want to help the most people possible. So, right, 1 million people if you have an artery problem. Now, if you think about what this brain stuff, if you lump in all kinds of things that are potentially related to what I call a glymphatopathy, but things like multiple sclerosis, pseudotumor, dementia, multiple sclerosis, chronic fatigue syndrome, fibromyalgia. I think these are all in part or in whole a product of a sick brain. And I think if we can measure why the brain is sick, or where the brain is sick, and what's causing it to be sick, I think we'll be able to help millions and millions and millions of people. So just to kind of wrap up again, venous stenting can lower pressure ICPs in a select group of people. I think stents can be used in other ways, not just in pseudotumor, but in treating whatever it is that you guys have. And I think that we need to think outside the box. We need to think beyond blood vessels and beyond just blood vessels, beyond just spinal fluid or just brain, and really try to combine. We need to think more. We need to think more globally. But anyway, that's kind of all I have to babble about. Any questions?
Are there any questions from the people on the WebEx?
They're asleep.
What percentage of this pseudotumor patients have venous thrombosis?
So,
Intracranial.
I would say probably 15% or less. There are patients who can develop a venous hypertensive or intracranial hypertension type disorder from a venous thrombosis. But the patients that I see, it's very, very, very few. I think a lot of people often ask me where this narrowing or where these narrowed veins come from, and it's actually, if you, we have been, I think I have a resident in Virginia working on this, but it's actually the brain. It's kind of weird. It's actually the brain itself that's squishing these veins. And it starts this vicious cycle where the brain kind of squishes the veins, and the blood flow starts to get bad, and the blood backs up and makes the brain swell, and the brain squishes the vein even more. I think a lot of the patients with pseudotumor that I treat have that kind of thing. Now, how that plays into EDS, I'm not quite sure yet, but it's.
Are you treating with anticoagulation in these patients when you put the stenting?
Yes, very. Whenever a patient gets a coronary stent or an arterial stent, they're typically on dual antiplatelet agents for 6 months or so. On the vein side, I used to do 6 months, then I started doing 3 months, and now I only do 30 days. And we haven't seen, I myself haven't had a stent thrombose, so we haven't seen any thrombotic complications yet. So I don't know what that means. Maybe these patients don't need to be on antiplatelet agents, or maybe they need to be, it could be another agent such as a heparin derivative that's maybe a better blood thinner for these people.
Okay, thank you.
You mentioned, sorry.
I was going to ask if you chose to work with Ehlers-Danlos, or if the Ehlers-Danlos population sort of chose you. And on the flip side of that, if a patient goes to see someone who's doing similar work to what you're doing, but isn't EDS savvy, are there consequences to that?
I don't know how to answer the first question. I think my goal has always been to help as many people as possible, and to be honest, I find you guys fast. I was so busy in Virginia that my practice actually got very, very boring, because everything that I saw was not to sound brash, but I knew how to fix everything, and so I got really bored, and then as soon as you guys came along and you guys represent it was like a puzzle, and I really kind of wanted to figure it out, and it's one of those things where the more I kind of looked into it, the more I realized that I didn't know what I was doing, and what they're teaching in medical school is wrong, and a lot of what doctors learn is maybe not absolutely correct, and sort of the more we looked into things, the more confused I got, but at the same time, it sort of helped me understand how little we know. To answer your second question, I just last night I heard of a patient whose daughter was fired by their physician because I don't know everything looks normal. I can't help you. I don't know what's wrong with you. Unfortunately, I hear stuff like that too often. I am trying to get other neurovascular surgeons to try to keep an open mind and think about treating patients with Ehlers-Danlos, or to modify their indications. I can't say right now that any permanent damage occurs because people see the wrong physicians, but I think it's it certainly doesn't make you guys feel good when you're told that, when clearly something is wrong, and doctors are telling you that everything's fine.
You mentioned in one of the studies that 40% of the CT angiograms showed stenosis of the transverse sinus. But I don't know anyone who just had a CT angiogram. It's not a procedure most people get unless they have a headache or something wrong to begin with. Does that skew your interpretation a little bit?
That's a great question. I can't remember what the main reason these people were getting CT angiograms. A lot of them were getting angiograms because they were seeing me for their brain aneurysm, and so I think a lot of them were, a lot of brain aneurysms, unruptured brain aneurysms, are asymptomatic. I don't know what percentage, off the top of my head, I don't know what percentage, but my understanding was that these patients were, I think they were, basically didn't have any major complaints of headache. Yes.
I was just wondering if you're also going to be looking at improving people's sleep disorders. So often people with chronic pain conditions really recover a lot in the area of chronic pain anyway, and headaches or something, if they just get more restorative sleep.
Yeah, no, I think I can't, as of yet, I don't know of a surgical procedure that can help with sleep. Interestingly,
No, but I just wonder if you could take away the problem. Avoiding surgery, unfortunately for you, but anyway, I just wonder that sleep just tends to be the biggest. It just solves a lot of problems if you can get more restorative sleep.
it does,
And
and
if they could get rid of it that way,
yeah, I think that's a great idea. There are some I do think there are some cases where no matter how much somebody sleeps, their brain may not be able to adequately clean itself.
Sure.
And certainly I've had quite a number of patients who, after a stenting or a shunting procedure, say they're starting to sleep through the night now, which is, I don't know why that is, but.
So for those of us that have all these comorbidities and have seen a lot of the doctors in this room and are getting by, or some of us are absolutely not getting by that are watching tonight, now that you've moved to Hershey, what protocol is there any pattern to going to you, or is it just, I know you book far out and you book you and then you come and start, or there studies locally or suggestions you have for if we really have a good idea that it's related to the field that you're working in? Should we step here again first before we come to you, or how does
That's a great question. I really try not to market myself as an EDS physician, because I honestly don't really know anything about EDS. I just happen to see a lot of patients who have EDS or have Chiari or have a lot of these comorbidities. I think if you try to fix everything, for a physician, it's almost like drinking from a fire hydrant. There's too many things. It's too confusing. And so what I and this may change in the future, but what I really try to do is focus focus on whether your symptoms may be a blood flow issue or a spinal fluid flow issue, and those are things that I feel pretty good about offering treatments for those. Certainly I think there are probably a lot of conditions that have not been traditionally thought to be treated by shunting or stenting where shunting, I think I'm starting to acquire a small population of people who, thanks to Dr. Rowe, have they do, patients with like chronic fatigue syndrome or fibromyalgia do derive some benefit from optimizing either blood flow or spinal fluid flow.
Is there significance if someone has a much larger venous system on one side of the brain than the other, more dominant side? Do you see that more common in people with connective tissue?
Yeah, I don't know that I see it more common in patients with connective tissue disorders. It's something that we see, I would say, fairly commonly. The way people are made. Most people are born with a large vein on both sides. Some people are born with either a small vein on one side and a big vein on the other side, or just one big vein on one side. And again, because I'm not very bright, I have to think of it. I have to simplify the situation so I can understand it. And I think as we understand it now, as long as blood has a way to get out of the head, whether it's through the large vein or whether it's around the spine, as Dr. Henderson alluded to, then the brain seems to get by. But as soon as that major pathway is mucked with, then that's when the brain starts to have trouble. I don't think asymmetry is necessarily unique to patients with connective tissue disease. I think I see a lot of patients without connective tissue disorders that have veins that kind of look the same. So.
We'll take one more question.
To piggyback off of Dr. Henderson's question, your stats show it's kind of normal to have stenosis, to walk around and operate just fine. but do you see the stenosis of bilateral, people walking around with bilateral stenosis just fine?
Yeah. And I see a lot of patients with blood vessel problems. So a lot of the patients I see either they're coming to see me for an aneurysm or a stroke or an AVM or something like that, where sometimes the residents always laugh at me because we're in there fixing one problem like an aneurysm, and then during the angiogram I notice that both of their transverse sinuses are blocked. And I kind of giggle to myself because I say, oh, this patient's going to need a stent too. But a lot of those patients never end up needing a stent. So, again, it's easy for physicians and surgeons like me to try to simplify a problem and say this is whatever is going on is just a blood flow thing. When your brains get sick, it's just a blood flow thing. When I think in reality, blood flow may be just a small part of the bigger picture, whatever that might be.
All right.